Thank you for that rescheduling. Thank you. Yes. So, preoperative corneal haze in pediatric cataract, is it predictive of development of secondary glaucoma? So, aphakic or pseudophakic glaucoma is a vision-threatening complication of congenital cataract surgery, usually an open-angle type which can occur years later in aphakic or pseudophakic eyes, and a closed-angle one may occur soon after surgery. The very factors like rubella, which produces cataract, can cause glaucoma as well. And known predictive factors in developing glaucoma after congenital cataract surgery are microphthalmia, early surgery before 3 months of birth, PHPV infections like rubella and cytomegalovirus. And central corneal thickness has been found to be high among aphakic children. Wang et al. In their study showed that central corneal thickness has a predictive value in the development of glaucoma. So our purpose was to analyze the association of corneal haze before congenital cataract surgery to the development of secondary glaucoma. This was a retrospective analysis among 36 children of 23 children who had cataract surgery before 5 months of age during the period from 2018 to 2021 in Contrast Eye Hospital in South India. A detailed dilated slit lamp examination noting an abnormality of anterior segment, fundus examination when possible, and B scan was done in total cataract. All had pediatric evaluation to rule out other associations, and torch titer was done for all. Under anesthesia, slit lamp examination, corneal diameter, axial length with A scan, keratometry with handled keratometer, and IOP with Perkins was done. Selected children with unilateral cataract and corneal diameter above 10.5 millimeter and axial length above 19 millimeter had IOL implantation. All bilateral cases were left aphakic. And ECC, the procedure, ECC was done through two 1 millimeter side ports, anterior capsulotomy, with microrhexis forceps under high molecular weight viscoelastic, lens aspiration, polishing, primary PPC with the help of trip and blue, and a shallow anterior vitrectomy with tricot assisted with or without IOL, and suturing of the side ports with Vicryl. Postoperative steroid antibiotic topically was given for 6 weeks to 2 months, hometropin for 1 to 2 weeks. They were followed up 1 week, 1 month, 2 months, and every 3 monthly thereafter. FAK correction was given from day 1 to day 7 onwards. Contact lens was given to suitable unilateral cases, and patching at least for 1 hour instituted in unilateral cases from day 1. During follow-up visits, retinoscopy, fundus examination, and Perkins IOP whenever possible, and slit lamp examination was done. Those who showed a myopic shift of refraction or whom we suspected glaucoma, EUA was examination under anesthesia was done to rule out glaucoma. And intraocular pressure, corneal diameter, axial length, goniometry, and CCT were done. There were 36 eyes of 23 children, 14 girls and 9 boys who had surgery before 5 months of age. 13 children had bilateral cataract and 10 were unilateral. The mean age at the time of surgery was 87.7 days in bilateral cases, ranging from 66 to 150 days, and 57.7 ranging from 48 to 90 days. 3 unilateral cataracts had IOL implantation. All others, 33 eyes, were left aphakic. 7 eyes among unilateral cases had microphthalmia. 2 children with bilateral cataract had microphthalmia with corneal diameter less than 9 millimeters. And microphthalmia was seen in 70% of the unilateral cases. 6 eyes, 4 unilateral and 1 pair of bilateral microphthalmic eyes showed corneal haze before surgery. And 4 children had rubella titer for IgG, which was high, and one had CMV titer for IgG and IgM titers, which were high. Mean preoperative IOP was 16 millimeters, and 3 eyes had membranectomy following surgery. 2 of them had IOL implanted. During follow-up, 5 children developed ocular hypertension. None of them had a second procedure. 4 were unilateral, and one eye of a bilateral cataract, and 1 was rubella positive. The earliest post-op period of detecting a high in IOP was 3 months following surgery, and the latest was 20 months. The mean CCT in aphakic eyes was 613 microns postoperatively among 20 children who had EUA. On analysis, it was found that corneal haze was documented in 4 of the 5 cases diagnosed with glaucoma. That is 80% of these glaucomatous eyes. All 4 had corneal haze and their CCT was above 640 microns post-operatively, but their preoperative CCT was not taken. After a course of timolol, maleate and dorzolamide, 5 had to be taken up for surgery. 2 had trabeculectomy with mitomycin and 3 had Ahmed valve drainage procedure. IOP is controlled by surgery in 3 and 2 are being followed up with timolol. So, Wong et al. Have shown that an increased CCT is a risk factor for developing aphakic or pseudophakic glaucoma, and none have shown a preoperative haziness of cornea in cataract. It is shown that CCT increases much more in children who had surgery at very early age, and it has also been shown that aphakic children with microcornea have higher CCT and higher measured IOP. Therefore, in these cases, follow-up of cup disc ratio is crucial, and though postoperatively, aphakic and pseudophakic eyes have been shown to have higher CCT, preoperative CCT has not been studied much. Simon et al. Have shown a comparison of CCT before and after surgery and followed up to show that CCT increased after surgery and in aphakia much more so than in pseudophakia. Central corneal thickness and corneal haze may be a factor determining the high IOP, which may all predispose to developing glaucoma after cataract surgery. It is good to look at the CCT and corneal clarity and IOP before cataract surgery to closely monitor them postoperatively if necessary. And other factors like microphthalmia, early surgery, and intraocular infection like rubella have to be taken into consideration. Thank you.